off to Beth Rose.
Thank you, Caroline, for those introductions. My name is Beth Rose, and my pronouns are she, her, and I am one of the co-founders of Alaska Eating Disorders Alliance. Jenny Loudon is the other co-founder, and we are so excited that all of you are here today. This spring's Project Echoes build upon the eating disorder echoes that Akita offered last year. And you can find presentations on those echoes on the box link if you want to learn more. Please remember, you won't be able to get credit for those, but there's a lot of good information there that you can peruse. The goal of the Project Echo is to work together to grow capacity within our local healthcare system to better understand, diagnose, and treat eating disorders. We know the issues of weight bias and stigma are particularly relevant, and today's presentation will address those topics. We encourage participants to use language that is welcoming and non-stigmatizing. Today's didactic presentation is by Dr. Christine Peat and is titled Eating Disorders and Higher Weight Bodies. Dr. Peat is the director of the National Center of Excellence for Eating Disorders and is an associate professor of psychiatry at the University of North Carolina at Chapel Hill. She has focused her clinical psychology practice and research in the area of eating disorders since her time as an undergraduate and has completed a postdoctoral fellowship in eating disorders at the University of North Carolina. Her research centers on eating pathology across the spectrum with a distinct focus on binge eating disorder. We are anticipating about 25 minutes for live Q&A after the presentation, live Q&A and discussion. And so we encourage you to think about the questions you'd like to ask Dr. Peat, and to the colleagues on the Zoom. You can, if the questions pop up for you, you can put them in the chat box now. Grace is going to summarize some of it. There's multiple questions along the same lines. Grace will summarize those and direct those to Dr. Peat. And then later you'll be able to unmute yourself as well. So without further ado, I'd like to thank Dr. Peat for being here today and pass the session over to her.
Great. Thank you so much, Beth, and thank you so much for having me here. I guess it's this afternoon where everybody is. So really appreciate the invite and the opportunity to speak with you all about eating disorders as they might present in higher weight bodies. I'm hoping that there'll be lots of good time for discussion and questions afterwards. So, you know, as folks have kind of foreshadowed here, please feel free to start putting those into the chat as the presentation progresses, and I'll be happy to take any questions that kind of come up live as well. All right. So I recognize that the first couple of slides that I'm going to present may actually end up being review for many of you if you've been to any of these ECHO presentations or at least familiar with the field of eating disorders. But I think they really do bear repeating, especially knowing that we're talking about eating disorders in a population that is often overlooked for these conditions. So just in terms of leveling the playing field, I think it's important that we do a little bit of myth busting when it comes to eating disorders and who they might affect. So one of the most common misconceptions is that eating disorders are rare, but in reality, we know that these are common conditions affecting roughly 28 million Americans at some point in their lifetime. This is a number that I think is much higher than a lot of people would really think, but this means that, you know, folks that are in your clinical practice, folks that are your neighbors or family or loved ones have struggled with an eating disorder at some point in their life. And so when we think about, you know, who is vulnerable, I think it's really important that we're thinking about pretty much anybody you know, that might be here in the US. And abroad, of course, but we'll be talking a lot about sort of US specific things today. We also know that eating disorders occur in every sex, gender expression, race or ethnicity, sexual orientation, any kind of really sociodemographic characteristic. Eating disorders don't discriminate. I think it really goes against a lot of the stereotypes that are out there in terms of what someone with an eating disorder might look like. But in reality, we know that this can happen to anyone at any point in their life. That means that not only are children and adolescents struggling with these conditions, but we also know that people that might be in their adult years or even their midlife or later years, they can have brand new onset eating disorders. So again, I'm kind of belaboring some of these points to get us thinking early on about the way that we might already be thinking about eating disorders and how we might be inadvertently excluding some folks that might be struggling with these conditions. Importantly, for the context of this conversation today, we also know that eating disorders occur in all body sizes and at all weights. There is not one particular weight that someone must have to have an eating disorder diagnosis. And we'll talk a lot more about that as today's presentation goes on. But I think that's one important myth to sort of bust early on here in the presentation, and for us to kind of hold as we go through the rest of this afternoon. Unfortunately, we know that eating disorders are certainly life-threatening conditions. These are conditions that have the second highest mortality rate, really second only to opioid use disorder when it comes to mental health and substance use. But the good news here is that these conditions are treatable. And so for those of you that are clinicians, those of you that are sort of working in these kind of healthcare spaces, I think it's really important to remember that the sooner we can get folks linked up with care, usually the better the prognosis. So it's wonderful that you all are here and taking the time out of your day to kind of increase your capacity to do some of this work as this echo was designed to do. So thanks so much for making the time here. So when we think a little bit about who might be struggling with an eating disorder, I really like to leave folks with this set of images. These are the folks that are going to be struggling. And these might not be the folks that immediately come to mind if you do a Google image search, or if you're looking at, popular culture, or looking at, news pieces or talk radio, or talk shows that might be on TV talking about who struggles with an eating disorder. But in reality, it's these folks. So when you're thinking about the patients that you work with, I think it's really important to think about all of them as potentially being vulnerable to an eating disorder, although of course not everyone will have one. I also want to do just a little bit of a refresher when it comes to eating disorder diagnoses. I'm not going to belabor a lot of these points because, again, I think for many of you that come to these echoes regularly, this is going to be information that's already fairly familiar to you. But I do want to hit a couple of high points, again, just to make sure that we're all kind of working from the same definitions when we're thinking about eating disorders. So what you can see here are a listing of a couple of different eating disorder diagnoses, and I have intentionally started with something called other specified feeding and eating disorder, or what we call OSFED. OSFED is not a terribly interesting term. However, it's basically a diagnosis in which individuals are struggling with, a handful of symptoms from some of the other eating disorders that you might be already familiar with. So for example, if somebody is struggling with binge eating disorder, but they don't meet every single diagnostic criterion, they're going to meet for what's called OSFED. And in fact, because of this, OSFED is actually the most common eating disorder diagnosis. I know that many of the other ones may more immediately come to mind, things like anorexia nervosa, bulimia nervosa, even binge eating disorder. But frankly, OSFED is a thing that you're most likely to see in a non-specialist setting. Of course, if you're in an eating disorder specialty clinic, you're going to see the full gamut, but really OSFED is the most common, particularly in non-specialist spaces. The other diagnosis I wanted to highlight is something called binge eating disorder. And again, when we're thinking about eating disorders in higher weight bodies, I think oftentimes there is already this assumption that if you're in a larger body or if you're in a higher weight body, then you must be struggling with binge eating. We know that that is certainly not the case. There are lots of folks that live in smaller bodies that also struggle with binge eating disorder. But we do know that there is an increased risk for binge eating among folks that might be living in larger bodies. So I do want to make some time to make sure that we're talking about that diagnosis here. The hallmark feature of binge eating disorder is really these recurrent episodes of binge eating where individuals are experiencing a sense of being out of control, a loss of control over their eating, and then they're eating sometimes unusually large amounts of food. So the hallmark here for a binge eating episode is not the amount of food that you're eating, it's really the sense of being out of control. I cannot stop eating once I've started. Even if I wanted to stop, I feel like I can't. And it's really that feature of binge eating that for so many people is incredibly distressing. Some folks almost describe it as like an out of body experience, almost like they're dissociating because they have so little control over their eating behavior in that time. The other eating disorder diagnosis that many of you are likely familiar with is anorexia nervosa. And the defining feature here is actually not necessarily weight. The defining feature of anorexia nervosa is an intense fear of gaining weight, and such that somebody is restricting how much they're eating throughout the day. For many individuals with what we would call threshold or kind of more stereotypical anorexia nervosa, they are getting to a really low body weight. However, important for the context of this conversation, there is something called atypical anorexia nervosa, which we often think about as sort of anorexia nervosa in a higher weight body. So these are individuals that have all of the same cognitive and behavioral features as somebody with threshold anorexia nervosa, but they simply don't meet that weight criterion. And I've put a little QR code here on the side for those of you that might be interested in some extracurricular reading. There was actually a really nice piece done by the New York Times a few months ago, kind of detailing the experience of people with this particular diagnosis, their difficulty with getting diagnosed, getting into care, because they don't fit that stereotype of what somebody with an eating disorder might look like, in particular, something like anorexia nervosa, which we often associate with being really low weight. One of the other eating disorder diagnoses that I think is worth talking about is bulimia nervosa. And here, this is very similar to binge eating disorder, where individuals are having those same kinds of binge eating episodes where they feel out of control, but they pair that with what we call an inappropriate compensatory behavior. So that might be things like self-induced vomiting, abuse of laxatives, diuretics, or water pills, exercise. It's sort of the pairing of those two things that really makes the hallmark of bulimia nervosa. And then lastly, just to briefly touch on another very common diagnosis these days, avoidant restrictive food intake disorder, or what we call RFID. The defining feature here is a diagnosis in which individuals are failing to meet their nutritional needs. They're simply not getting in what they need to fuel their bodies on a daily basis. Many of you here who have been paying a close attention might be thinking that sounds an awful lot like anorexia nervosa, and in many ways it does, and there can be some overlap. However, these individuals don't necessarily have a fear of gaining weight. They don't have a fear of fat. They don't have that same cognitive presentation as folks with anorexia nervosa or atypical anorexia nervosa. These are folks that are just failing to meet their energy needs, either due to a lack of interest in food, difficulty with the sensory characteristics associated with food. Maybe there were some aversive consequences associated with eating, like choking or vomiting. And it's those sorts of things that are driving the restriction and not so much sort of a fear of weight gain, if that makes sense. So, now that we kind of have a lay of the land, we sort of understand what eating disorders are, what the various diagnoses might be. I want to spend a little time more specifically talking about what we know about eating disorders in individuals in higher weight bodies. So this was taken from a publication, and I've hyperlinked all of these in the slides, and you'll get a copy of the slide deck at the end of the presentation. But all of the, I'm almost certain that all of the articles that I've linked to here are available publicly. So hopefully these won't be behind a paywall, but if that is the case, please just reach out, let me know. I'm happy to send a copy. But the table that you're looking at here comes from a publication that came out a few years ago. And let me walk you through this because it can be a little bit dense. What you can see across the top in bold are the various eating disorder diagnoses that we just talked about. They put these in alphabetical, no, they didn't. They put these in sort of more typical order. So anorexia nervosa, bulimia nervosa, binge eating disorder, and then the other two that I think are maybe less commonly known. What you can see down the left-hand column are some of the different eating disorder criteria. So that might be things like an overvaluation of weight or shape. So, your sense of what you look like, that number on the scale is a big part of how you see yourself in the world. A fear of fatness or behaviors that prevent any weight gain, having an underweight status, weekly binge eating episodes, inappropriate compensatory behaviors. All of these are kind of different building blocks of different eating disorder diagnoses. And what I want to draw your attention to is that the only diagnosis that requires being underweight, so requires having a low weight or a low BMI, is anorexia nervosa. Threshold anorexia nervosa. So if you look across this row here, you can see with underweight status, it is required for a definition of threshold anorexia nervosa. It's not necessarily present in bulimia nervosa. It's not present in binge eating disorder. Underweight might be present for those folks with RFID, those folks who are failing to meet their nutritional needs. And it may be present in OSFED depending on the presentation. But really, this is the only eating disorder diagnosis that requires an actual physical status of being underweight. And I think it's really important that we think a little bit about that, especially in the context of those who are living in higher weights. So, what is it about the threshold definition of anorexia nervosa that requires that underweight status? What do we know in terms of the research? And again, I'll just be frank here with this group. it's still sort of a little bit of a TBD. Our understanding of something like atypical anorexia nervosa is not nearly as robust as it is about anorexia nervosa. So I think we're still learning. But I wanted to highlight this because I think it's really interesting when we think about these diagnoses. If you look at the left-hand side, all those basic building blocks of an eating disorder diagnosis, underweight really only applies to one diagnosis when we think about all the different eating disorder diagnoses that are out there in this landscape. And so I think it may sort of have an outsized influence when it comes to who we think about struggles with eating disorders and how you get diagnosed. Because if you ask sort of the average person on the street, what do you think about when you hear the term eating disorder? They're often going to say, well, I think about somebody who's really skinny and doesn't eat, right? But in reality, that criterion really only applies to one diagnosis, and it's actually the most rare diagnosis out of all of them as well, right? So just again, I think something good to keep in mind. We talked briefly at the beginning about this definition of atypical anorexia nervosa, and I do just want to give a quick caveat for those of you that are sort of data nerds or sort of classification nerds. Atypical anorexia nervosa is technically under the OSFED diagnosis. It is a type of an OSFED diagnosis. So if you're looking for it in the DSM, it's going to show up under OSFED. But for our intents and purposes, I really just want to talk about this as a discrete entity. So atypical anorexia nervosa, again, is what we think about as anorexia nervosa in higher weight bodies. These are folks that literally meet every other criterion when it comes to anorexia nervosa, except for that weight piece. But one of the problems is that these are individuals that are commonly missed in clinical practice. And again, I think if you think about that stereotype of who's affected by an eating disorder, or the mental stereotype that comes to mind when you think about anorexia nervosa, that really applies here. Because if we're thinking about who that stereotype is, if somebody comes in at higher weight and you're a healthcare provider, you may not even think to screen that individual for an eating disorder, just assuming that because they're not thin or because they're not underweight, that they must not have an eating disorder, right? And so one of the other things that we know is that many folks with atypical anorexia nervosa is that these folks may end up presenting for treatment later in the course of their illness, because even the affected individual may not recognize that what they're doing is consistent with an eating disorder. And unfortunately, there's also this misperception that atypical anorexia nervosa is less serious, less important, less severe than anorexia nervosa. And I'm going to help dismantle some of that throughout our time here this afternoon. But I just kind of wanted to throw out this idea that this is a diagnosis that is often overlooked. One of the other really interesting things, though, that came out of this, some of this research, is that there's actually been an increased prevalence of atypical anorexia nervosa in specialty eating disorder programs. The research literature, I think, really points to this, but also as a clinician here at UNC in Chapel Hill, I can absolutely vouch for that. I would say within the last 5 to 6 years, we have seen far more cases of atypical anorexia nervosa than we had seen in the previous 5 to 6 years. The research study that I'm citing here found that atypical anorexia nervosa can actually account for up to 45% of patients in an inpatient medical stabilization unit. So again, these folks can actually be really medically brittle. And in fact, one inpatient program reported a 5-fold increase of atypical anorexia nervosa over a 6-year period. So again, we're talking about the highest levels of care that are available for eating disorders. And so if they're seeing that at the highest levels of care, we're certainly seeing that at the lower levels, like outpatient, for example. So when it comes to some of these medical complications of atypical anorexia nervosa, what are they? And why is there this misperception that this is a less severe or less maybe important eating disorder? What you can see here was taken from this publication. This is a table directly from their manuscript. And what you can see is in terms of the different medical complications, there might be, renal difficulties, cardiovascular difficulties, GI complications, endocrine, neurologic, skeletal, all of these different areas where you're also going to see the same kinds of complications that you might in other eating disorder diagnoses. So again, I think we have good factual evidence to indicate that folks with atypical anorexia nervosa may actually have many of the exact same medical complications as folks with threshold atypical anorexia nervosa. I do want to be cautious, though, in saying that it's not as though then this particular research study proves that these two diagnoses are the exact same. That is not necessarily the case. If we had enough research, then maybe we'll start to move in that direction. But in many ways, this research is still in its nascence. Part of why I'm bringing this up, however, is I do want to highlight this idea that this is a serious eating disorder. It does require specialty treatment, and there can be some very severe consequences. And this isn't something we can afford to just kind of sweep under the rug. And so a little bit more about what we know about atypical anorexia nervosa. There have been all these questions about, if it's not that different from threshold anorexia nervosa, why do we call it something different? In what ways might it be different from a more threshold anorexia nervosa? And so I wanted to walk us through some of this together. There was a really good systematic review and meta-analysis that was published a few years ago, and I'm going to basically walk you through some of their data. But before kind of walking you through some of the finer points, I wanted to unpack a little bit of their methodology so that we all have a shared understanding of what it is that we're looking at here. So what you can see at the top in this top row here are the different ways in which these researchers searched for publications that were relevant or were about atypical anorexia nervosa. So they did, oopsie, my computer is misbehaving. So they did a search on a database called PubMed. They did a search on a database called PsycInfo, one through a manual search, and then a couple of other search engines like ProQuest, for example. These are all fairly well known. For those of you that do this kind of research, you're probably very familiar with these platforms, but in the event that not everyone here is, I just wanted to recognize that these are different search engines, sort of like academic Google in some ways, where they searched for articles that were about atypical anorexia nervosa. And you can see that through PubMed, they found 124 articles, PsycInfo 81, a manual search yielded 2, and so on and so forth. So after they removed all the duplicates from those different search engines, there were a total of 293 articles that were about atypical anorexia nervosa. What they did is they removed the ones that weren't in English, because this was going to be sort of an English-focused study. They removed the ones that did not use the DSM-5 definition of atypical anorexia nervosa, which was a good chunk of those. They removed those studies that also only included less than 10 participants in the study. Some of this has to do with basically the methodology around systematic review and meta-analysis. If there's only 10 participants, it's really hard to draw meaningful conclusions from those data. And then they removed any studies that didn't compare folks with atypical anorexia nervosa to some kind of control group. And so once they removed all of those that basically were ineligible for this particular study, they were left with 24 different studies. So they went from a total pile of initially 293 down to a total of 24 studies that we're going to talk about in the context of this particular study here. So what you're looking at here is what's called a forest plot. And I'm going to walk you through some of this because we're going to look at several forest plots in a row over the next couple of slides. I'm going to just sort of unpack a little bit about what we're looking here. So I'm going to start with the title, because part of what we're looking at here is a forest plot comparing the gender distribution of individuals with atypical anorexia nervosa versus those with threshold anorexia nervosa. So what you can see up here at the top on the left-hand side are the different studies that looked at the gender difference between these two diagnoses. So a study by Foreman and colleagues in 2014 looked at this, Garber and his or her colleagues in 2019, so on and so forth. So there were a total of 7, if I'm adding correctly, studies out of those 24 that were looking at the gender breakdown in comparison with atypical anorexia nervosa and anorexia nervosa. And what you can see here is that based on the pooled estimates, if you pool all of these studies together, all of these participants together, individuals with atypical anorexia nervosa had a greater proportion of males than individuals with threshold anorexia nervosa. Now, what I want to unpack here briefly is that this does not mean that atypical anorexia nervosa happens more in men or that it happens less in women. The idea is that if you have a group of folks that have atypical anorexia nervosa, you're going to have more men in that sample than you might in a sample of individuals with threshold anorexia nervosa. So I think it just kind of goes to show that there might be greater gender heterogeneity among individuals with atypical anorexia nervosa, whereas those with threshold AN are more likely to kind of be mostly female, if that makes sense. Same idea here with another forest plot. I'm going to start with the title so we know what we're looking at. So this figure here is showing the difference between an atypical anorexia nervosa sample and an AN sample when looking at the racial or ethnic distribution of these individuals with these diagnoses. There were 5 studies here that were reporting on this. And what they found is that among individuals with atypical anorexia nervosa, there were a greater proportion of individuals who were non-white. Again, caveat here, this does not mean that individuals with atypical AN were mostly non-white. It just means that there were more non-white individuals in that sample. Overwhelmingly, most of these folks were still white women across all of these studies, which we can talk about in terms of limitations in the research sample. There's lots to discuss there. But I think the hallmark here is that in addition to there maybe being a greater proportion of men with atypical anorexia nervosa, there's also going to be a greater proportion of individuals who are non-white with atypical anorexia nervosa. So already we are bumping up against 2 stereotypes that are very strongly held when it comes to eating disorders, because so many people assume that eating disorders really only affect white women, right? But with something like atypical anorexia, we're already kind of busting some of those myths, and also maybe helping folks understand why this condition is often overlooked, right? Because, if you have a couple of different patients in your office throughout the day, you may not think to screen your male participant or your male patient for an eating disorder. You may not think to screen your non-white patients for eating disorders. Again, not because you're not a good clinician and because you don't want to do the right thing, but more that it's not part of your schema. It's not how you think about eating disorders. So I think that these type of data are really important for us to be looking at. Another forest plot to look at in terms of the BMI, I'm sure this won't be surprising. Most of these studies looked at BMI, and what you can see is that in comparison to anorexia nervosa, those with atypical AN tended to have a higher BMI across all of these different studies. And again, that's also what we would expect, right? Because when you look at the DSM-5 criteria, basically we're being told that they have all of the same features of anorexia nervosa except for weight, right? So that's fairly straightforward. This slide here, however, is showing the BMI in comparison, comparing those with atypical AN to healthy controls. And what you can see is that individuals that have atypical anorexia nervosa actually tended to have a lower BMI than individuals who were healthy controls. Right? So even though they may have elevated weight in comparison to their peers with threshold anorexia nervosa, they may have lower BMI in comparison with their healthy peers. Again, something I think that's really important to keep in mind, because unless you work in a specialty clinic, you're not usually going to be comparing an eating disorder patient with an eating disorder patient. You're going to be comparing somebody with an eating disorder to somebody who doesn't have one. And so even if their BMI is elevated in comparison with, some of the folks with more threshold AN, it's important to consider that these are folks that still may have lower BMIs than some of your other patients. So again, a lot of this is kind of relative depending on the way that you practice, but I thought this was particularly interesting because it's maybe more of an unexpected finding. One of the other things that this particular meta-analysis did was look at some of the other features that are often associated with eating disorders, things like depression, for example, almost invariably goes hand in hand. And what you can see here is that individuals with atypical anorexia nervosa were typically just about as depressed as individuals with threshold anorexia nervosa. So that little green diamond crosses that middle line, meaning that there really isn't a statistically significant difference between the two groups. It has to be on either side of the line for there to be a statistically significant difference. And so I think it's important to note that patients with atypical anorexia nervosa may be struggling with depression that's just as significant as your patients with threshold AN, which I think kind of gives a nod to how significant these conditions can be in terms of really just kind of taking over your life and affecting your daily well-being. Similarly, what we found is that if you compare those with atypical anorexia nervosa to controls, to healthy controls, those with atypical anorexia nervosa are certainly more depressed. And again, we would expect this, right? So if you have an eating disorder, you're almost always going to be more depressed or more anxious than your healthy controls, but it's good to see this here in the data. When it comes to menstrual disturbance, which is this particular forest plot here, it's what they're comparing those with atypical anorexia nervosa and those with threshold AN. And what you can see is that it's less typical for folks with atypical anorexia nervosa to have menstrual irregularities. That doesn't mean it never happens. It just means that it's less frequent. So something to keep in mind when we're thinking about, the profile of these folks with this condition. And then they also looked at bone density, and what they found is that there actually tends to be a higher bone mineral density in folks with atypical anorexia nervosa. Not entirely sure why. I don't know that we have causal reasons for this, but we know that folks with threshold AN tend to have less good or less dense bones. But it sounds like those with atypical AN may actually have more bone density. Lots of reasons to sort of have questions about that and do some additional research. But again, just trying to present the full scope here. Um, the other thing outside of atypical anorexia nervosa that I wanted to touch on briefly when we think about eating disorders in higher weight bodies is the diagnosis of binge eating disorder. What we know is that this is a particularly common eating disorder, especially among higher weight persons who are attending weight loss programs. So, those of you that might be involved in weight management programming, I would almost expect that you have some of these folks in your clinic. And in fact, 42% of individuals with lifetime binge eating disorder were at a higher weight during the time that they were surveyed in this particular study here. So just knowing that there tends to be a lot of overlap. Again, it's not a perfect overlap, but it is something to pay attention to. Um, Also, many individuals will report that binge eating disorder is, I'm sorry, that weight stigma is one of the big reasons that they actually didn't end up getting diagnosed with an eating disorder in the first place, or it may be something that contributed to the maintenance of their binge eating disorder. And we're going to talk a little bit about what that means here in a moment. But I just also want to say that there does tend to be some controversy about whether or not this idea of overvaluing your weight and shape should be a part of the diagnostic criteria for binge eating disorder. Right now, it is not. If you have this particular diagnosis, you don't necessarily have to endorse having this overvaluation of weight and shape, but so many of our folks with this diagnosis do. I think there are a lot of people who sort of question why it might not be a part of the diagnosis. So, why is it that eating disorders in higher weight bodies are often overlooked outside of some of the reasons we've already talked about? I think a big one really has to do with the role of weight bias. There's this assumption that if you are at a certain weight, then maybe you don't sort of fit the description of somebody with an eating disorder. But above and beyond that, we know that weight bias creates some real barriers and real consequences for individuals that live in higher weight bodies. So not only are these individuals going to be struggling with things like depression, anxiety, poor body image, we also know that these are individuals that might be less likely to present to healthcare in the first place because of the shaming experiences that they've had. So if you're not going to see a clinician, hard to get detected with an eating disorder, right? Maybe these are conditions, maybe the weight stigma itself is something that has driven you to be even more secretive about your eating disorder, making it less likely that you reach out for help, right? So weight bias is something that we know is prevalent and sort of predominant in our culture, but I think it's important to think about the role of weight bias and whether or not people get detected with these conditions and whether or not they actually end up seeking care for it down the road. So how does weight bias impact eating pathology? Well, we know that it's correlated with lots of risky eating pathology behaviors, things like risky dieting, maybe that's fasting, maybe it's over exercising, it might be binge eating that's followed up by self-induced vomiting. And so many of our folks with these conditions will often report a fear of being fat or a fear of gaining weight. And if that's your whole fear, if that's kind of how you've oriented your world, it makes it really difficult then, I think, to be in a world in which you're being told, well, you don't really have anorexia nervosa because you're still too large, right? Because your BMI is still too high. You may inadvertently get the message then that your eating disorder isn't serious or it's not important. But I think again, I'd love to hear some discussion from you all or questions from you all about what you've run into or kind of seen in your practice. But there are lots of different ways that this weight stigma can contribute to eating pathology and also maintain the diagnosis over time. So, if you're thinking a little bit about what you can do as a clinician, and I might breeze through some of this in the interest of time because you'll have these slides and none of this is rocket science. But I think as a clinician, no matter what you do, whether you're in primary care, whether you're in mental health, whether you're in nutrition, if you can really have this idea that all foods fit, that overarching principle can go a long way. So, I think it's important to examine our own personal and professional biases when it comes to things like clean eating, whether or not we're recommending processed foods or non-processed foods to our patients, and really thinking about how we define healthy eating, right? Because sometimes there can be some real judgment when it comes to these foods that may end up inadvertently reinforcing these stereotypes around eating disorders. And that's really important to think about when we talk to ourselves, but also our patients when it comes to food, because food has no moral value. There are these comments that you see up here, things like, I feel so guilty for eating that last piece of pizza, or I can have a cookie, I've been good today, right? These might be fairly innocuous comments that you might hear colleagues make, maybe even in the break room of wherever you happen to work. But those kinds of comments also really inform your worldview about what foods are good, what foods are bad, and then inadvertently how you might interact with a patient when you're talking about food and diet, right? So it's important to do some of our own work when we're thinking about that. In a similar vein, I think reminding ourselves that all bodies are good bodies is an important overarching principle. Your health status is not equivalent to a number on a scale or to how someone looks. I think all of us in here can appreciate that your health status is made up of myriad factors, not just a number on a scale or not just a dress size, for example. So making sure that we're thinking about the full landscape of health can really help us, meet the needs of our clients and of our patients. Also thinking a little bit about exercise, because I know that we spend a lot of time talking about the need for physical activity. It can be a mood boost. It can be a great way to make sure that you're regulating anxiety, depression, those sorts of things. But if we are recommending it specifically as a way to lose weight and saying, well, you need to lose X number of pounds, so I'm going to recommend that you exercise X number of minutes per day, it can quickly turn into something that becomes disordered for many folks. Instead of movement being something that's joyful for individuals, it can turn into something that folks are doing to earn their food, which we certainly wouldn't want to give the message is a healthy approach to eating. And also just remembering that weight and does change. Your weight will fluctuate throughout your lifespan. Your weight fluctuates throughout the day, right? Weight is not a static number. And so remembering that not all patients who are experiencing weight changes are necessarily going to require direct intervention. And so I think it's really important that we're doing careful assessment, not making an assumption that because a patient has gained weight or a patient has lost weight, that they necessarily need to have a particular intervention, but really instead thinking about the whole person and their whole picture of health. My slides have a mind of their own today, so thank you for your patience. As a clinician, outside of kind of some of those overarching tenets, what are some of the things that you might be able to do? We're going to encourage you to learn more, right? Not only coming to these echoes, but learning a little bit more about how you might manage some of these conditions in your clinical practice. As Beth mentioned at the beginning, I'm the director of the National Center of Excellence for Eating Disorders, and our whole ball of wax is to provide education and training on these conditions, specifically to healthcare providers. Our mission really is to make sure that healthcare providers and the general public are receiving information that's evidence-based on these conditions to ensure that individuals with these conditions are identified, treated, and supported in recovery. And so our website, which I've also hyperlinked, you'll have access to all of these, gives you access to not only our suite of on-demand trainings, but also a really robust resource library that you can filter based on the type of healthcare provider or the type of, excuse me, it's allergy season here in Chapel Hill, or the type of stakeholder that you might be. So all of that is available for free and on demand. And we have also created some curated resources for those of you that are here today. So again, you're going to have access to all these slides, but we've created QR codes for each of the different kinds of stakeholders that you might be or that you might be interacting with that are specific to today's presentation. So all of that is freely available for use, and you're able to access this, after the presentation. It's not going anywhere. So we would encourage you to take advantage of those resources and to certainly reach out if there are any questions. To that end, my email address is here. You're welcome to be in touch with me after today's presentation. I'm also happy to take any questions with the time that we have remaining. I know I'm running over by a couple of minutes, so thanks for your patience with all of that. And I will turn things back over to Beth and maybe Grace, I think.
Sounds great. Thank you so much, Dr. Peat, for this presentation. You packed so much in there, and I learned quite a bit, as I'm sure that everybody else did as well. I took some notes here, but I'm really glad that this presentation is being recorded. It will be available in our Project Echo box, and we'll have Dr. Peat's slides. And right now, I want to open up the floor to questions. This is the concept of Project Echo is all teach, all learn. So don't be shy about asking questions. Grace Schumacher, who's an RD and a certified eating specialist. She's an AKITA board member and the Alaska president of the International Association of Eating Disorders Professionals. will be moderating the questions. So there are some already in the chat that I know people have been already talking about a little bit. Grace may bring those forward. And then feel free to raise your hand or unmute yourself. And I'm going to turn it over to Grace now.
Thanks, Beth. Yes, this is very conversational. I have quite a few questions that have come in that I wanted to get to today, but as always with the ECHO project, feel free to chime in, introduce yourself before you speak if you wouldn't mind. Question number one, Christine, when there's a need to go into a medical setting where weight is part of that check-in process, some individuals struggle with that. Can you talk about the process for someone who's in a higher weight body and how clinicians can help to diffuse some of that emotional discomfort?
Yeah, I think that for a lot of folks, if they're going into an urgent care visit for, maybe a bruised wrist, or maybe they had some sort of accident, they're sort of surprised that they end up getting weighed, given that they're here for stitches. And I think that for a lot of folks, that can be really off-putting, especially at the beginning of a medical visit. I think that, there's been some really good guidance from some different organizations that are out there that are HAES aligned, that have actually given folks some step-by-step guidance about how they might approach those situations. And so, I would point you to organizations like ASDA, the Association for Size Diversity, and I can't remember the exact. If Beth or Grace happen to have access to those hyperlinks, they can put them into the chat, or some of the other HAES organizations, because they actually have developed some really beautiful guidance. But just in terms of paraphrasing, I think one of the things that they've encouraged folks to do is to advocate for themselves and to say, is this a necessary part of my visit? Can you help me understand, what's being measured or what's being monitored here? If you feel uncomfortable knowing that number, you can always ask for a blinded weight. And if folks don't know what that is, you can educate your healthcare providers. You can help them understand that means that I don't want to see the number. I don't want it in my chart. I don't want it said out loud to me after I've been weighed. That may seem obvious to many of you here, but it isn't to a lot of folks. So, it can be a little bit scary to do that kind of advocacy for yourself. And it is something that I think, some of the health at every size groups have really talked about being a very effective way to have that conversation, and something that makes you feel more empowered in your own health journey. So it's a great question, and one that I think we grapple with on a regular basis.
Can you,
Thank you.
excuse me, I have
go ahead.
a question. This is Chris. I have a question. Can you talk a little bit about the onset of eating disorders or disordered eating before puberty, how common that is, but then you don't really see the actual symptoms, like maybe weight gain. I'm not, or extreme, but I'm looking in my case of more weight gain. But how common is that? And where do you intervene? It's the adolescents that I'm most concerned about right now. Thank you.
Yeah, absolutely. And we do have a lot of adolescents and children who are struggling with eating disorders, particularly in the wake of the pandemic. So I think it's a great question. I guess my short answer to the first part of your question is yes, we see many folks that will have an onset of eating disorders prior to puberty. And in fact, one of the things that commonly gets missed is that there are kids who may fall off of their trajectories, whether that's, height, weight, BMI. They may fall off of their growth charts in a way that doesn't really get picked up on or accounted for. And I'll give you a great example, specifically since we're talking about folks with higher weight bodies. If you have a kiddo who is typically trending in, let's say, the 75th percentile for BMI, they've just kind of always lived there. That's where their body tends to live. They, they might have been larger as kids, and as they've gotten older, they've gotten taller and developed more. They still just hang out at the 75th percentile. We can oftentimes see these kids fall off of that percentile, fall off of that growth chart, and end up getting down to, let's say, the 50th percentile, maybe the 45th percentile. And a lot of times these kiddos get missed because instead of suspecting that there might be an eating disorder going on, there might be the suspicion, there might just instead be sort of a congratulations about weight loss. So instead of, being at that sort of elevated percentile, these kids have fallen off, and the PCP or pediatrician might think, oh, great, their weight is kind of normalizing, right? They're losing weight. But I think that, again, if we're just going based on weight or just going on BMI, we lose a lot of that really important picture, because these are kids that are maybe eating 200 or 300 calories a day. These might be kids that are exercising for hours on end in their bedroom and not telling anybody. They're engaging in behaviors that are incredibly risky and things that we frankly wouldn't accept for folks that live in smaller bodies, right? So, I think that's maybe one fairly long-winded way to talk about, how some of these symptoms can have an onset before any frank eating disorder symptoms like, self-induced vomiting or binge eating symptoms. So, Chris, to your question, I think that, routine and regular screening of children and adolescents, the more that we can do that, the earlier that we can catch these conditions and get folks linked up with appropriate care. It's a great question.
And going back to that question, Christine, how do you figure in puberty and eating disorders? When should a clinician really be concerned? We know that it's not really about the weight, but how do you figure in puberty?
Yeah, I think that one of the things that's really important is to take a look at everyone's charts, everyone's information individually. It's really hard to give like a cross-cutting, here's the age or here's the point at which you should be concerned, because every kid is different, just like every patient is different, right? You might, if you work in a pediatric practice, you might have one kid at the beginning of your day that's at the 75th percentile. You might have one that's at the 40th. You might have one that's at the 65th. So it's hard to really say, at what point we should start to be concerned. I think generally speaking, what a lot of my medical colleagues will talk about and recommend is that you take kind of a generally sort of 10,000-foot view approach. If you're noticing deviations in weight, deviations up, deviations down, if you're noting deviations in terms of mental health signs, depression, anxiety, anything that hasn't been typical for that kid, that's a reason to lean in a little bit and ask a few more questions. Doesn't mean you're diagnosing somebody, doesn't mean you're accusing somebody of anything. It's just a reason to show a little bit more curiosity, because if this kid has always been trucking along at the same kind of pace, and then suddenly we have a deviation in one way or the other, there's a reason to ask about that, right? So I would say that if we're thinking about sort of whole health for these individuals, particularly adolescents, it's important to think about their overall trajectory and the way in which they might be deviating from that versus looking at a specific number, if that makes sense.
Excellent, thank you. We do have new questions coming in, and I will get to those as I'm monitoring the chat. I just wanted to move along here. We're curious, Christine, for someone who is experiencing atypical anorexia or significant reduction of eating below their estimated energy needs, for those patients that are not losing weight or not progressively losing weight, are there reasons why?
So just make sure I understand the question correctly. Folks that might be restricting significant amounts of calories from their diet, but they're not necessarily losing weight, why might that be?
Correct.
Yeah, it's a good question, and not one that I'm certain I can answer, definitively. But one of the things we do know, and this comes straight out of all the dieting literature and the weight management literature, is that actually for many individuals who live in higher weight bodies, when you restrict, when you stop eating throughout the day, because for many people, what they end up doing is just cutting out entire meals. It's not necessarily smaller portions throughout the day, but they might cut breakfast, they cut lunch, they might try to eat one small meal at the end of the day. For a lot of those folks, what they've done is slow down their metabolism. So even if they're only eating very few calories throughout the day, you may not necessarily see the scale budge. Again, we're not recommending this as a strategy for anyone. I think the idea, though, is that for many individuals, who live in higher weight bodies, especially those that may have yo-yoed over the years, it's not as simple as calories in, calories out, or fewer calories in, fewer, or like that doesn't necessarily correlate with, a specific decrease on the scale. And I think that frankly is one of the reasons that when it comes to weight, whether that's in a weight management clinic or it's in the context of eating disorders, there is so much heterogeneity. There is not a single path to sort of, somebody's eating disorder development or their weight trajectory. If it were as simple as calories in, calories out, then I think, there wouldn't be sort of as much controversy as there is. But yeah, for many individuals, it really has to do with a slowing of their metabolism. But, certainly not for everybody.
Another question that has come in, or several questions that have come in about diets that could be recommended for people in higher weight bodies, perhaps patients in higher weight bodies who are hoping for some weight loss. How would you go about recommending that?
Yeah, this is a tough question, because I think that if you are a clinician who really wants to do right by your patients and are really trying to meet them where they're at and help them get to their health goals, you want to support them when they have certain thoughts or ideas or goals for themselves. However, I think if you talk to most eating disorder experts, that they're going to recommend that if you have something like atypical anorexia nervosa, binge eating disorder, that it's actually contraindicated to be involved in weight management programming at the same time. And it's for a number of different reasons. Stereotypical weight management programming often involves cutting out large numbers of calories. Maybe you're on liquid diets, maybe you're doing other sorts of things. But when it comes to foundational eating disorder treatment, which Grace, certainly you can speak more eloquently about this than I can, we're prescribing a regular pattern of eating to everyone, irrespective of your diagnosis. We want everyone eating roughly 3 meals, 2 snacks per day. And if you're in a weight management program that's telling you, well, I don't want you eating two of these meals, I want you just drinking a shake, for example, it's going to be really hard to make good progress in the eating disorder if that's the sort of larger context that you're living in. So I think it really has to do with the goals that patients have. And I won't lie, there are many individuals, for example, that come to our specialty clinic here with binge eating disorder and say, okay, so I have binge eating disorder. Yeah, that's all fine and well. I'm pretty sure my binge eating disorder will go away if I just lose weight, right? If I could just lose this weight, then I'm sure I wouldn't binge eat anymore. And that's got to be the answer. So if you could help me lose weight, then I'm sure it would help get rid of my binge eating. And we sort of walk them through their treatment options. We let them know what's available, but we also are very honest with folks that binge eating disorder treatment is not designed to be a weight loss treatment. It's designed to help you stop binge eating. And we can't make that be somebody's goal. We can't force that to be somebody's priority, but we can be transparent about their treatment options and what treatment is designed to do. And then patients can make an informed decision for themselves about what's right for them at this point in their life. So I know that's not a perfect answer, but it is kind of what comes to mind here for me.
Thank you. We're just about out of time. I wanted to respond to that too from a nutrition perspective, from a dietitian perspective. For individuals who are seeking some kind of a weight intervention, whether that's keto or intermittent fasting or any number of weight loss diets, that more than doubles their risk for developing disordered eating and a clinical eating disorder. And then I believe that we're out of time. Do we have time for maybe one more question?
One quick question and one quick response, if we could do that.
All right.
Sure.
Very briefly, there's a question here about the LGBTQIA2+ individuals. Are there studies, as perhaps there's just a lot that deals with male and female genders?
Yeah, there are actually a growing body of studies looking at eating disorders in all kinds of minoritized communities, particularly those in our queer community. And I think that that research is not nearly as robust as we want it to be. But I think that over time, we're learning that certainly these are folks that could be an elevated risk for eating disorders, particularly our folks that are identifying in the trans community, just given, I think, some of the body dysmorphia. That's a whole other talk and lots, I think, of good, rich discussion there. But yes, there is a growing body of research. There are some concerns that some of the unique stressors that community faces may actually make people vulnerable to an eating disorder or may maintain their eating disorder over time. Great question.
Well, I'm going to jump in here now and thank you, Dr. Peat, for this. This is obviously a discussion that we could have for at least another half hour or hour. We last time that we did our eating disorder echoes, we had an hour and a half. We also had a case presentation, but we're trying to do this over the lunch hour. So thank you, everybody, for attending and for your questions. And again, Dr. Peat's slides and this recording will be in the box, the echo box. So there's a few other things we just want to share with you. And Grace, thank you also for moderating. Just wanted to share with you a few things. If you've signed up for this one, you will also be registered to join us on May 3rd with Dr. Ovidio Bermudez, who will be speaking on avoidant restrictive food intake disorder. And if you're seeking some really interesting training where you can get longer credits and work with other professionals, Akita will be offering April 26th through 28th, a training with Dr. Laura Hill on temperament-based treatment with supports. It's a 3-day in-person training in Anchorage. We wanted to price it incredibly reasonably to allow people to come. And it's using neurobiology of eating disorders and genetic traits that will help you learn how to use strength-based approaches to help people recover from eating disorders. It's been shown to lower resistance from clients and increase motivation. So highly recommend that you come to that. We do have support groups for adults 18 plus and also for family and friends. So if you're either in those categories yourself, or if you have a client, please go to our website and you can register for that. And I think this is already noted, but the session recordings of presentations and such will be posted within 24 to 48 hours after the session. And we just really wanted to thank you for joining us today. The engagement of this learning community is so important. Whether if you're here, you're showing up, you're asking questions, you're sharing your experiences, these elements are really invaluable to us. So please keep in touch with us. We're doing 2 echoes, as I mentioned, this one now, and also in the one that will be May 3rd, we will be planning a series of at least 4 more echoes in the fall. If you want to be involved in any way and sharing with us what you're interested in, some of the topics that are of the greatest importance to you, please do let us know. And we're actually a couple minutes early. So that's, I think, is what we went through everything. I'm going to see if Sharon has any comments, anything else that we need to do. I think all the links are in the website, are in the chat box. Is there anything else, Sharon? And if not, so the question about the CEUs is that the link is provided in, I'm looking here in the website. We do have, is this in here somewhere? We don't have this here. Somewhere there would be the links to the CEUs and the opportunity to do a
They're in
survey.
the chat. Yep, they are in the chat.
Okay, great. Here we are. Perfect. So you've got the Survey Monkey. And so please fill out the survey, which is brief, and then you go to the rest of the form to receive and download a certificate for your CEUs. So thank you all. I really appreciate you being here today. And we'll see you on